This lecture is about ankle sprains. It's in the Part 15, Ankle and Foot Pain. We know that in the United States, foot and ankle problems are extremely common, with an incidence of about 24% in middle-aged and older adults. So what is a sprain? It's a ligamentous injury caused by abnormal motion, a sudden change in direction, or a misstep on an uneven surface. Even a minor ankle sprain jeopardizes joint stability. Epidemiologically, ankle sprains occur in all ages, but about 15 to 20% are from sport injuries. Previous ankle injuries increase the potential for reoccurrence, and also early diagnosis, treatment, rehab, and subsequent ankle support during activity decreases the reoccurrence of a sprain. Pathogenesis, there's two kinds of injuries that cause ankle sprains. The most common is an inversion injury. The foot plantar flexes and internally rotates as the ankle inverts. And the ankle, or the roll injury, the lateral ligaments, and can cause a lateral avulsion fracture. So you have to keep that in mind. The less common is called an eversion injury, or an external rotation mechanism, and this injures the medial structures of the ankle, damaging the deltoid ligament or the syndesmosis. So those are the two kinds. What happens when they clinically present? And I think most of us are familiar with this. It's usually they present with a swollen and a painful joint. There's bruising and decreased range of motion. Often weight bearing causes pain, and some patients cannot even tolerate to bear any weight. And you always ask if they heard an audible snap or a pop at the time of injury, because this is one clue or indicator of a more serious injury. It certainly can. Immediate swelling and bruising raises suspicion for a fracture or a substantial amount of joint involvement. So asking about that snap or pop, and then immediate swelling and bruising. So they may report at the time of injury a sensation of lightheadedness, nausea, or diaphoresis, because it's such a traumatic event. Physical exam reveals a swollen, bruised, and edematous ankle, whether it's medial or lateral, and it's quite an illusion of deformity, especially with a lot of swelling and bruising. There's limited active and passive motion, and point tenderness are very common because of the amount of swelling and edema. Joint laxity is present in more severe sprains, so that's something you can keep in mind as you're assessing. Muscle spasm can prevent testing of strength and stability just from that injury and those muscles being damaged, and then the reaction is spasm. Severe sprain tenderness may extend up the extremity, and so you want to evaluate above the injury, and actually the entire extremity that's affected should be palpated and assessed. So diagnostically, guidelines for radiographs are controversial. Severe injuries should be x-rayed, or order plain x-ray of the lower leg if there's tenderness at the fibular head. And I have a wonderful tool that I use. It's called the Ottawa Ankle Rules, and I'll include that in this module. Okay, it's really helped me, especially when I began to practice, and I follow those rules, and the evidence bears witness that they're very accurate. Radiographs can be used to exclude an avulsion injury if you're worried about that. And then stress films, CT or MRI scans can be considered with the consultation of an orthopedic surgeon. I think when you're thinking about stress films, CT or MRI, then you're looking at a much more serious injury that needs orthopedics involved. Management, the severity of the sprain dictates the management. And I want to refer you to page 898 and look at Table 171.1, and it's classification and treatment of ankle sprains. And it goes over the grading system, that grade 1 through 3. And you need to know that information if you were asked to grade a sprain, okay? So rest and protection, ice, compression, and elevation. RICE is the acronym, as the first key steps to pain relief and minimizing swelling. And that conservative treatment works the majority of the time. And then reassessing after they have done this is very helpful. Nonsteroidals are helpful orally if they don't cause GI symptoms, but you can also use topical nonsteroidal gels. Experientially, my patients do say that the GI, the orals are more effective, but that just is really an individual patient thing. TED stockings support the entire lower limb, but sometimes are quite uncomfortable if you're trying to get them over a swollen ankle and foot. Casting for 10 to 14 days for a grade 3 sprain is often necessary when it's that serious of a sprain, and it really can lead that patient to rehabilitation quicker. All sprains require rehab to restore stability. So whether it's a grade 1 to 3, and very often we're the ones that are teaching them what kind of rehab is to occur after they get over the initial injury. Treatment and recovery can take weeks, and rehab should begin as soon as possible with range of motion and strengthening. I keep, now that we have internet, but I keep handouts of these things. Referral, fractures, dislocation, grade 3 sprains, they do require orthopedic referral. And I think, the first two we're very familiar with, but even a grade 3 sprain, it should be in that same category. Physical therapy may be required to promote rehab because they want to maximize their service to minimize their time to recovery. And then patient and family education, you just really need to stress the RICE and avoid weight bearing on the injured ankle as much as possible. Reiterate the medication doses and possible side effects. Proper elastic bandage wrapping technique is important, the figure 8. Cast care or crutch use. You cannot assume that they understand. They've got to look for signs and symptoms of a tight cast or impeded circulation, and then the crutch use can create more damage under the armpit if you don't teach the correct use. Rehab processes and reoccurrence risk also need to be emphasized because it's much more common. Thank you.